So right now, NHS boards across the UK are actively auditing patient records. They're trying to track down this specific, highly dangerous medical error.
Yeah, it's a massive clinical undertaking.
Right. And it's all because um, women are being prescribed menopause treatments that could actively harm them, all because of this widespread misunderstanding about a tiny T-shaped piece of plastic.
Exactly. I mean, we are seeing these NHS learn from patient safety events or LFPSC alerts, basically flagging cases where patients are being put at severe risk.
Just because of bad timing, right?
Pretty much, simply because the intersecting timelines of their medical devices and their hormone therapies just, well, they aren't being tracked properly.
Which brings us to the core mission of this deep dive. We're taking a stack of medical guidelines from the Faculty of Sexual and Reproductive Health Care, the British Menopause Society, and various NHS trust formularies to answer one really highly specific, incredibly important question for you.
And it's a question a lot of people have.
Yeah. If you already have a Mirena coil for contraception, can it automatically serve as the progesterone component of your HRT?
The short answer is yes. But the mechanics of how it does that and the strict timelines governing when it actually stops being safe, well, that's where those medical errors are happening.
Right. The devil is in the details.
It really is.
Yeah.
You have to understand the biological mechanism to actually understand the rules.
So let's ground this in the biology right away because the sources are so adamant about the dangers of unbalanced hormones. So if we think about the endometrial lining the tissue inside the uterus like a lawn,
That's a good way to picture it.
then systemic estrogen therapy is essentially Miracle-Gro.
Yes, exactly.
You are adding this powerful fertilizer to your system to treat, perimenopause symptoms. And it causes that endometrial lawn to grow thicker and thicker. So what does this all mean if you take estrogen without the brakes?
Well, left to its own devices, that continuous growth becomes pathological. You can't just apply Miracle-Gro indefinitely.
Right. The grass would just take over the whole yard.
Precisely. You need a gardener to come in and continuously mow that lawn, keeping it maintained. And in the human body, progesterone is the gardener.
Okay, so without that gardener, the clinical guidelines warn about a condition called endometrial hyperplasia without atypia.
Yes.
Now, the Chelsea and Westminster Hospital formulary explicitly states this is not cancer. But I want to break down what's actually happening at a cellular level here because it sounds scary. What does without atypia actually mean?
It's a crucial distinction, really. So hyperplasia simply means excessive cell proliferation. The cells in the lining are multiplying way too fast because of that unopposed estrogen.
Because of the Miracle-Gro.
Right. But without atypia means that if you look at those cells under a microscope, their internal structure, like their nuclei, their distal shape, it remains completely normal.
Oh, okay. So they haven't mutated.
Exactly. They haven't mutated at all. It's strictly a numbers problem, an overgrowth problem, not a mutant cell problem.
So the lawn is just incredibly overgrown, but the blades of grass themselves are still just normal grass.
Precisely. However, if you leave that lawn overgrown long enough, the sheer volume of rabid cell division increases the statistical probability of a mutation occurring.
Ah, so it's a numbers game.
Very much so. The sources indicate that if endometrial hyperplasia without atypia is left untreated, there is a risk it's less than 5% over 20 years, but still a very real, completely preventable risk that those cells will eventually mutate.
And develop atypia.
Right. And then progress to endometrial cancer.
Wow. Which explains why the NHS safety audits are so aggressive about this right now.
Exactly. Prescribing that estrogen Miracle-Gro to someone with an intact endometrium without ensuring they have adequate progesterone to, mow the lawn, it isn't just an oversight.
It's a critical threat to patient safety.
It is, unless, of course, the patient has had a hysterectomy.
Right. In which case there is no lawn to fertilize.
Exactly. A patient without a uterus can take estrogen safely without any progesterone at all. But for anyone with an intact uterus, the biological requirement for that progesterone protection is absolutely non-negotiable.
Okay, let's unpack this. This is where the Mirena Coil enters the picture as a potential solution. We already established the answer is yes, it can act as your HRT progesterone.
It can, yes.
And people love the fit and forget convenience of the coil. But the sources highlight a massive difference between, say, swallowing a daily progesterone pill and utilizing a Mirena.
Right.
It comes down to systemic versus localized delivery right.
What's fascinating here is how it works so completely differently than oral pills. Oral progesterone, like the commonly prescribed body-identical Utrogestin capsules, is systemic.
Meaning it goes everywhere.
Right. When you swallow that pill, it has to be processed by your digestive tract, metabolized by your liver, and then pushed through your entire bloodstream just to deliver the required dose to your uterus.
And pushing it through the entire bloodstream is what causes all the collateral damage, isn't it?
Yeah.
There's a lot of people taking oral progesterone report severe mood changes, fatigue, bloating.
Yes, the side effects can be quite heavy for some.
If I remember the neurology correctly, oral progesterone crosses the blood-brain barrier and converts into a metabolite called allopregnanolone.
That's right.
And that heavily binds to GABA receptors in the brain, essentially acting like a potent sedative.
That is exactly the mechanism. It's why oral progesterone can make people feel so incredibly sluggish or emotionally flat.
Which nobody wants when they're already dealing with brain fog.
Right. But the Mirena bypasses almost all of that. It's an intrauterine system loaded with 52 milligrams of levonorgestrel, which is a synthetic progestogen.
Okay.
Because it sits directly inside the uterine cavity, it releases that hormone locally straight into the endometrial tissue.
So how does that localized levonorgestrel actually stop the miracle grow effect of the estrogen? Is it just physically shedding the lining?
No, it's far more elegant than that, actually. The levonorgestrel downregulates the estrogen receptors within the endometrial tissue itself.
Oh, wow.
Yeah, it essentially turns off the tissue's ability to, see or respond to the estrogen circulating in your bloodstream.
That's amazing.
It also causes a process called pseudodecidualization, which thins the lining out on a structural level.
To borrow the analogy again, it's not just coming in and mowing the lawn. It is actively making the grass immune to the fertilizer.
Exactly. That's a great way to put it.
And because it's doing this locally, the amount of levonorgestrel that actually makes it out of the uterus and into the general bloodstream is, what, a tiny fraction of what you'd get from a pill.
Very tiny. Which means the blood-brain barrier isn't being flooded, the GABA receptors aren't being overwhelmed, and those systemic side effects like the severe mood swings and sedation are drastically minimized.
Which is a huge relief.
Yeah.
And beyond just protecting the endometrium, the sources point out that this localized approach manages two other massive issues simultaneously.
Right.
Because perimenopause involves erratic ovulation, so highly reliable contraception is still medically necessary. Plus, heavy menstrual bleeding is a hallmark symptom of this whole transitional phase.
Yeah, the Mirena is fundamentally a top-tier contraceptive device, but it is also specifically licensed as a clinical treatment for heavy menstrual bleeding, or HMB.
Oh, I didn't realize it was actually licensed for that.
It is. For about 20% of users, it thins the lining so effectively that periods stop altogether within 6 months.
Wow.
When you combine that with its ability to safely oppose HRT estrogen, you have a single localized intervention addressing 3 distinct major medical needs simultaneously.
I mean, it is a brilliant piece of bioengineering.
Yeah.
But looking through these British Menopause Society updates and the NHS safety alerts, the engineering isn't the problem. The problem is the calendar.
Yes. The timeline is the single most dangerous point of confusion for both patients and prescribers right now.
Okay, because wait, I just read that the Mirena license was actually extended to last for 8 years. So if I've had my coil for 6 years for contraception and I'm just starting estrogen for HRT, I'm fully covered.
No. And that assumption is precisely what is triggering the LFPSC medical error audits right now.
Wait, really?
Yes. This is the most critical takeaway. The 8-year license is exclusively for contraception.
Only contraception.
Only. If you are relying on that exact same Mirena device to protect your endometrial lining from daily HRT estrogen, the absolute hard limit is 5 years.
Let's interrogate that, because on the surface, it sounds completely contradictory.
Yeah.
I mean, it's the exact same 52 milligram reservoir of levonorgestrel, right?
Yes, the very same one.
How can it be perfectly effective for stopping a pregnancy at year 7, but dangerously inadequate for HRT protection?
It fundamentally comes down to the degradation curve of the hormone release.
Okay.
And, the biological threshold required for 2 completely different medical tasks.
Right.
When a 52 milligram Mirena is first inserted, it releases roughly 20 micrograms of levonorgestrel every 24 hours. But over time, that release rate drops. By year 5, it's down to about 10 micrograms.
And by year 8?
By year 8, it has dropped down to around 8.6 micrograms a day.
Why is 8.6 micrograms enough to prevent pregnancy, but not enough to protect against hyperplasia?
Because preventing pregnancy requires a microscopic amount of localized hormone. To prevent a pregnancy, the levonorgestrel primarily just needs to thicken the cervical mucus to block sperm motility.
It's sort of like a physical barrier.
Right. And it alters the localized environment just enough to stop an egg from implanting. It's a very low-bar biological mechanism.
But counteracting HRT estrogen is a much heavier lift, I assume.
Immensely heavier. With HRT, you are supplementing your system with continuous daily doses of estrogen. You are actively and persistently pouring Miracle-Gro onto that lawn every single day.
Right, the constant fertilization.
Exactly. To force the downregulation of all those estrogen receptors and prevent cell proliferation against that constant stimulation, you need a higher, continuous concentration of levonorgestrel.
That makes total sense.
The clinical data shows that once the Mirena's daily release rate drops below the threshold we see at the 5-year mark, it simply cannot guarantee protection against hyperplasia.
Okay, the biology makes perfect sense. But the paperwork surrounding this 5-year rule is still incredibly convoluted.
It is.
Because if you look at the manufacturer's actual product license for the Mirena, it explicitly states it is only approved for 4 years as an HRT progesterone.
Yes, that's true.
So why are the Faculty of Sexual and Reproductive Health Care and the British Menopause Society telling doctors and patients that 5 years is the rule if the corporate paperwork clearly says 4?
Well, this exposes a really fascinating gap between corporate licensing and clinical reality.
How so?
When the manufacturer originally applied for the specific regulatory license to market Mirena for HRT endometrial protection, the clinical trial data they presented to the authorities only covered 4 years.
Why just 4?
Because running clinical trials is astronomically expensive. Once they hit their primary endpoints, they just submitted the data to get the product to market.
Oh, wow. So the 4-year rule isn't based on a biological failure at 4 years. It's literally just where the initial corporate funding for the trial stopped.
Exactly. But medicine doesn't stop at the end of a corporate trial. Medical bodies like the FSRH and the BMS rely on extensive post-market surveillance.
Real-world observational data.
Yes. And decades of longitudinal data have proven that the device reliably maintains that critical threshold of receptor downregulation for a full 5 years.
Which means when a doctor tells a patient their coil is good for 5 years of HRT, they are technically prescribing it off-label based on the manufacturer's specific HRT license.
Yes, technically off-label.
But they are completely supported by the highest standard of evidence-based clinical guidance in the country.
That's exactly right. The FSRH guideline is the gold standard here.
Yes.
But that 5-year mark is the absolute cliff edge.
So no pushing it to 5.5 years.
No. If a woman has had her Mirena for 5 years and 1 month and she wants to continue her HRT estrogen safely, an intervention is medically required right then.
What are her options?
She either needs the old device removed and a new 52 milligram device inserted, or she must begin taking a supplementary progesterone, like oral utrogestan, alongside her existing coil.
Okay, here's where it gets really interesting, though, because the moment we start talking about the coil as a generic concept, we run into another massive blind spot highlighted by these NHS safety audits.
Yes, the terminology problem.
Right. Mirena has essentially become a proprietary eponym. People use it to describe literally any hormonal IUD. But the clinical formularies list a whole spectrum of devices, and they are definitely not interchangeable when it comes to HRT.
Not at all. They're completely different pharmacological tools. We've established that the biological threshold for HRT protection requires a 52 milligram levonorgestrel device.
Right.
Mirena is obviously the most recognized brand, but the UK formulary also includes devices like Levocert and Benalexa.
Do Levocert and Benalexa follow the exact same 5-year off-label clinical guidance from the FSRH?
They do. Both contain precisely 52 milligrams of levonorgestrel. Their degradation curves mirror the Mirena perfectly, and the clinical guidance universally supports them for 5 years of endometrial protection alongside estrogen HRT.
Okay, good to know. But what about the lower dose options? Because I'm looking at Kyleena, which has 19.5 milligrams of levonorgestrel, and Jadis, which only has 13.5 milligrams.
Right.
They are dispensing the exact same hormone. Why are they excluded from HRT?
Because they start too low on the degradation curve from day one.
Really? Even on day one?
Yes. Kyleena and Jadis were specifically engineered for patients who want the absolute minimum amount of systemic hormone exposure required to achieve contraception.
Okay.
They are phenomenally effective at thickening cervical mucus to block sperm. But even on the very day they are inserted, their daily release rate is not robust enough to reliably downregulate estrogen receptors against daily HRT supplementation.
So if you try to use a Kyleena or a Jadis as your HRT progesterone, you are essentially leaving the lawn completely unmowed. You are fully exposing yourself to that risk of hyperplasia and cellular atypia we talked about.
Unquestionably, you're completely unprotected. And, that risk is exponentially higher if a patient is using a copper coil.
Oh, because copper intrauterine devices are entirely non-hormonal, right?
Exactly. They function by creating an inflammatory environment in the uterus that is toxic to sperm. They contain zero progesterone.
Zero.
Which means they offer zero protection for the endometrial lining against estrogen.
Wow. This connects directly back to why those NHS integrated care boards are running these massive audits. It must be incredibly easy for a busy GP to look at a patient's chart, see the acronym IUD or just the word coil, assume the patient has their progesterone needs covered, and just write a prescription for estrogen.
It happens all the time.
But if that coil is 6 years old, or if it's a Kyleena, or if it's a copper coil, that prescription immediately becomes a serious patient safety event.
It does, and the burden of vigilance is unfortunately falling on both the fragmented medical record system and the patient themselves.
Yeah.
It requires immense precision in medical coding by the doctors, but it also really requires the patient to know exactly what device is sitting inside their bottle, the exact milligram dosage of that device, and the exact month and year it was inserted.
Right, so let's crystallize the takeaways from this deep dive so you have the exact knowledge needed to advocate for your own care.
Good idea.
First, a 52 milligram levonorgestrel coil, specifically a Mirena, Levocert, or Benalexa, can absolutely serve as the progesterone component of your HRT.
Yes.
It provides an elegant, localized defense that downregulates estrogen receptors in the uterus, while largely bypassing the systemic side effects of oral progesterone pills.
Which is a huge benefit for so many.
Definitely. Second, it acts as a powerful triple threat during perimenopause, protecting the uterine lining, providing necessary contraception, and clinically treating heavy menstrual bleeding.
Right.
Third, low-dose hormonal coils like Kyleena and Jades, along with non-hormonal copper coils, simply do not possess the biological mechanism to protect your endometrium from daily HRT estrogen. They require completely separate progesterone prescriptions.
You cannot rely on them for HRT, period.
And finally, the clock is uncompromising. Despite recent news that Mirena is approved for 8 years of contraception, its ability to safely oppose HRT estrogen expires strictly at 5 years.
That 5-year mark is so critical. And, the evolution of that 5-year rule really leaves us with a profound insight into how modern medicine actually functions behind the scenes.
I mean,
Well, we tend to view clinical guidelines as these absolute rigid laws handed down from regulatory bodies. But the story of the Mirena in HRT reveals a much more fluid reality.
it exposes that gap between the corporate paperwork and the lived biological evidence.
It really does. The manufacturers stopped their clinical trials at 4 years, likely for financial or logistical reasons, and that remains the official product license.
Which is wild to think about.
It is. But the entire apparatus of women's healthcare in the UK, from the British Menopause Society to the FSRH, relies on doctors continuously observing real-world data, tracking patient outcomes over decades, and having the clinical courage to override a 4-year corporate label with a 5-year evidence-based reality.
It raises an incredible question for anyone navigating the medical system. How many other treatments, particularly in women's health, are governed by this invisible tension between what the corporate paperwork says and what the biological evidence actually proves?
It's a huge question, and it's one we should all be asking.
Exactly. That tension is exactly why navigating these diagnoses feels less like reading an instruction manual and more like mapping uncharted territory. Being an informed patient means understanding not just what the rules are, but where the rules come from and when the science has actually outpaced them. Thank you for joining us on this deep dive. Keep investigating, keep advocating for your own care, and keep asking great questions.